Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comms. The topic today is substandard and falsified antimicrobials and how they affect patients and antimicrobial resistance. I'm thrilled to have two expert guests with me. The first is Pernette Bourdillon Esteve, who is Technical Officer for the World Health Organization's Substandard and Falsified Medical Products Group here in Geneva, Switzerland. Before joining WHO in 2012, she worked for the United Nations Office Against Drug and Crime, DRIaDD, and the French Foreign Affairs Ministry. Pernette, welcome.
Thank you very much for having us.
And my second guest is Professor Ben Cooper. Ben is Professor of Epidemiology in the Nuffield Department of Medicine at the University of Oxford in the UK. In addition to leading clinical trials and observational studies, Ben uses mathematical and statistical modeling to help understand the dynamics of infectious diseases and the measures used to control them. In this context, he leads the Drug-Resistant Infection and Disease Dynamics Group, DRIaDD. Ben, welcome as well to Communicable.
Hi, thanks very much for having me.
I'm very excited to have both of you. So as our listeners know, we start these episodes with a sort of get to know you question for our guests. And we also turn it on ourselves to make you guys less shy. So I'm going to ask today, what piece of advice were you given that you've never forgotten? And I'll start. Mine is to show up and shut up. I'll explain. This was an older employee when I was doing a part-time job in the summer. He told me, look, for the first 6 months of any new job you start, the first 6 months you show up and shut up. And later you can always come and give your advice and give your opinion, but you should never do it in the first 6 months. And I have followed that advice. I think I've tried, and I think it has served me well. And I think it serves a lot of people well if they manage to do that. So how about you, Ben?
Yes, good questions. I think the piece of advice that's made the most impact on me has been to stop working and start thinking. And this was actually the title of a book co-written by my PhD supervisor, Graham Medley, with an extremely eccentric scientist called Jack Cohen, who actually features in Paul Nurse's Nobel Prize-winning speech, because he set Paul Nurse on his path to Nobel glory. But Paul Nurse described Jack Cohen as someone who was usually wrong, but always wrong in an interesting way. And Jack Cohen always really encouraged people to think really deep thoughts and think differently. So not just toe the common line, but really think about what they're doing. And I do think it's good advice, because a lot of times many people are just so busy working and so busy doing what's on their plate and getting stuff done that they forget why they're doing it or what they're doing. So I haven't always followed this advice, but when I haven't, I've always regretted it.
Definitely very wise. I think I'm one of those people who get caught up in all the tasks of the day and not stop and think. So if you don't mind, you can just transfer that advice to me. Thank you very much.
Okay.
Pernette, how about you?
I really like both of your advices. Angela, I think that the piece of advice that I remember is a little contradictory to yours and maybe a bit more in line with Ben's. So definitely always ask. And generally I'm asking why, and always ask for help. So always ask is, why are we doing this? Sometimes you end up doing something and you come in a little bit with a fresh perspective, and it's really important to ask why. It helps you be a little bit leaner or smarter in the way you work, and it always teaches you something. And I think that's probably what all scientists do. They're always asking themselves why. The other bit is ask for help. Really asking for help is a piece of advice I've never forgotten, and you'll always get something. And I have to say, in the past few years, the thing that's given me most probably cause for hope in humanity is the generosity in time and spirit and everything of people around me, who've always been extraordinarily generous in explaining things to me and helping me out. And no one person can know everything. We can't be polymaths anymore. And Ben said before, we're in a joint project together. And I'm incredibly humbled to be part of that project with Ben and the other scientists who are there. And I'm always amazed they just accept me. But the thing is, I've got a different perspective than them. So they know a bunch of things and I know a little bit of things, but it's about connecting things. So if you ask why and if you ask for help, it's really useful to move forward.
Yes, this is beautiful. And you put me to shame because now I feel really bad about my advice. I think that advice that I received to show up and shut up was more for like my part-time, not creative work that I did when I was younger to get through med school and whatnot. And no one should really show up and shut up. I didn't mean that at all. Okay, so moving on. And Pernette, I will always remember this advice as well, and I will live by yours and Ben's. All right, so to the actual topic. So beyond some vague awareness, I think many of us really are not well acquainted with the problem of substandard and falsified medicines. So first off, I will go ahead and quote some formal definitions from WHO. Substandard medicines are authorized medical products that fail to meet either their quality standards or their specifications, or both, due to factory errors or degradation in supply chains, so sort of honest errors in a way. Whereas falsified medicines are those that deliberately, fraudulently misrepresent their identity, their composition, or their source. Pernette, can you start us off with a broad introduction here? What are the nature and scope of this problem really right now?
We know it's a big issue, but we don't really know how big. And the reason we don't know how big it is, it's by definition, this is a hidden trade. A falsified medical product, everything's going to be done to deceive the person. With substandard medical products, they're also difficult to spot because you don't usually identify the quality defect until maybe you've done a lab testing or some sort of examination. So on one hand, we've got a clandestine activity, and those who are involved in their design clearly try to deceive patients. And for substandard products, they're also difficult to spot because they might have been not well manufactured or degraded, but they might not have a therapeutic effect. And lack of therapeutic efficacy is something that's really hard to spot, especially when you've got comorbidities. So WHO has been working on this issue for a very, very long time, for many, many years. And actually just this morning, I was looking at the number of times this has been referenced in World Health Assembly resolutions, and it goes way back to 1950. In the past decade, past 12 years, we've set up the Global Surveillance and Monitoring System because WHO has recognized this as an urgent health challenge. And what we've observed is that it's a pretty global issue. There's no reason to think that any market or any country is untouched. I started by saying that it's a big issue, but we don't know how big it is. It's difficult to quantify. So we've got a case reporting database with the limitations that entails, but every single main therapeutic category has been reported to us. And the analysis of that database shows us that the risk of substandard and falsified medical products reaching patients is greatest when you've got constrained access, weak technical capacity, and poor governance. So you don't need a single one of those issues, but the combination of those issues is what makes it worse, obviously. And we've also seen all sorts of product types being reported to us. So whether it's a question of affordability, acceptability, availability, all the therapeutic categories, everything gets reported to us, and it's a very global issue.
Yeah. It was a tricky question because obviously you don't really have the denominator. How do you measure this burden when WHO cannot surveil everything?
In 2017, so this starts to date back a while, WHO published a literature review. We did a meta-analysis of surveys that had been done in low and middle income countries to extrapolate the prevalence of medicines that failed quality control tests. So therefore, these products were either falsified or substandard. And that review found that more than 1 in 10 medicines in low and middle income country failed quality control tests. But there's obviously going to be very wide variations by region, by country, by therapeutic category, and things like that.
As a little follow-up question, I could imagine that the substandard problem is much more prevalent, I hope, than the falsified problem. Or am I wrong?
Yeah, I'll be cheeky here and I'll say, why is that important to know? From a public health point of view, the patient needs to get a product that's of the appropriate quality and that's safe. And a product that's substandard and a product that's falsified are not of the right quality, and they're therefore not safe. The reason we've got quality standards is to make sure that the products people receive are safe. We've got a case reporting system, so there are all sorts of biases in that. And so we do get somewhat more falsified products, but you can't extrapolate and say that this is more substandard or more falsified worldwide. So from a public health point of view, what matters is that a patient gets the right product.
I totally understand that. And thank you for pushing back on that a little bit. I mean, you're doing amazing work, but you're kind of doing detective work. Maybe in a way, falsified medicines, you at least know, okay, where is it coming from? What do I target with my resources? Can I shut down this organized crime ring of falsified medicines? Or am I still being very naive? She's laughing at me, Ben.
Ben and I are laughing because the project that we are working on is precisely the forensic epidemiology of antimicrobial medicines. There could probably be a separate podcast just on that.
Yeah.
It's very exciting stuff, all the tracking those crime rings.
Seriously, I was trying to ham up the drama.
With Ben and Paul Newton and everything, definitely.
Very exciting.
To get back to your question, so yes, there is a part detective work with huge quotation marks, and that is what makes this area of work so fascinating. It's absolutely cross-cutting. It goes to social and anthropological behaviors all the way to law enforcement and policy and things like that. And that's also what makes it challenging. You've got to work across lots of different types of stakeholders. However, actually identifying the criminal origin of falsified medical products is quite challenging. You need to have good multi-stakeholder collaboration. You need to have the resources to do the investigation. Whereas with substandard products, you generally know where they come from. I'm not saying that good manufacturing and distribution practices are easier to enforce, but at least the stakeholders are already mapped. And you have got all sorts of good regulatory practice systems in place that you can encourage people to follow, which is not going to be the case, of course, with falsifieds. So that's a little bit more of a challenge.
This is a perfect lead-in to my next question, Pernette, because in WHO's 2017 report on global surveillance and monitoring for substandard and falsified medicines, you give a nice figure, which is entitled, I think, A Medicine's Journey Across the Globe. Can you tell us briefly about this journey? It's not as simple as one medicine being made wholly in one factory and then being shipped to a hospital or a pharmacy, correct?
So yes, a medicine's journey is absolutely not that simple. So before you get to a finished product, you need active pharmaceutical ingredients, you need excipients, and all of that needs to come together into one place. The finished product is made. Then sometimes the finished product is made in one place, but then the packaging might be made in another place. And what you've got along the line is you've got an increasing number of transactions and an increasing number of stakeholders. So once the finished product is made and packaged, the manufacturer might sell this to a bunch of different wholesalers who all have got different types of statuses. Some of them might be public, some of them might be private, some of them might be very big and resell onwards to other wholesalers, to other distributors. And then it keeps going on supply chain to smaller and smaller redistributors until it reaches the patients. So what happens is you've got an increasing number of transactions and an increasing number of people who take part in these supply chain, the closer the pharmaceutical or medical product gets to the patient, which also means that it's more and more difficult to control the oversight of a medicine. Because what that map doesn't show is also the pre-existing history of a medicine, all the way from clinical trials. And all of these clinical trials tend to be well controlled. You've got one regulatory or two regulatory authorities controlling a very small handful of actors. But then it's impossible to know where product X has been distributed worldwide and to which patient in particular.
Thank you, Pernette. Ben, can you give us some background specifically on substandard or falsified antimicrobials in particular? Not just medicines, but really antimicrobials. What is the scope of this problem and what is the nature of it? Do these versions have less than the expected amount of antimicrobial in them? Do they actually tend to have more or both? Can you tell us a little bit about these antimicrobials?
Yeah, sure. So the problem is very diverse. It's not that they always have more active pharmaceutical ingredients or always less. And in fact, some of the falsified medicines could have the correct amount of active pharmaceutical ingredients. So there's no sort of one size fits all there.
I think, what Ben said is absolutely correct, and it's really important. There's all sorts more products, more active ingredient, not enough, the wrong one, the correct one, and with contamination with something else. The quantity of the active pharmaceutical ingredient is often taken, the assay as the key marker, but that's not the only thing. You've got to think about the bioavailability. So we've seen products with the right amount, but it's not being made available in the correct way.
Interesting. And Pernette, can you give us a concrete example, a sort of anecdote of substandard or falsified antimicrobials that WHO has had to investigate? And what were, if any, the clinical ramifications for patients in your anecdote?
Unfortunately, we've got lots of different examples or anecdotes of substandard and falsified antimicrobials where we've had to bring assistance to countries. So what basically WHO does is we've got this case reporting system, and we record the information, we process the information, we validate it. But when it's necessary, we will also provide in the short term technical assistance to those countries who need it. Not every country needs our assistance on every single incident, but there are cases where that happens. There's an old case, but it's quite emblematic, several years ago, where we had a report from a doctor in a country in West Africa who contacted us somewhat in a panic because that doctor was treating a patient on a regular basis with benzosine penicillin. And this was not the first time that the patient was taking this injection. An hour or less after having received their injection, that 10-year-old girl collapsed. And it was all the symptoms of anaphylactic shock. The thing is, it wasn't the first time that the patient was taking this product. And so we assisted in facilitating the laboratory analysis of the remaining samples. The problem is there was very, very little samples that were left, and we were not able to identify the problem in the product itself. However, we were able to confirm that this was a falsified product. And so in this particular case, the investigation support that we did was understanding the root cause of the problem and therefore recommending, of course, another product. There's a bunch of examples like that throughout the existence of our database where we've provided laboratory assistance, connecting people with one another as well. That's an important one. Just last year, we published what we call a WHO medical product alert on tetracycline hydrochloride, which is an ophthalmic treatment. What's happened is we received a report from a national NGO, non-governmental organization, of adverse reactions. So there were red and swollen eyes after the application of the product. The scale and scope seem to make it an unexpected adverse reaction because it's not just about adverse reactions, whether or not they're expected. So we facilitated the inspection of the supplier and the manufacturing facilities. There was not enough evidence to support the data integrity. So we realized that the manufacturing site had a couple of issues, and we helped with the quarantine of this product and the replacement. It's quite rare that we're able to identify the origin of where a falsified product might be manufactured. In the example I just made, it was a substandard product. These examples I gave you, the one in West Africa with the benzosine penicillin, or the antibiotics in the Caribbean, or this in the Middle East, we provide different types of assistance. And these are the actual antibiotics, which are the problems in itself. But we've also got products which are contaminated with pathogens that might be more or less resistant. So we've also issued a couple of alerts on methotrexate, which is a product that's given to cancer patients. So these are patients who are already vulnerable, and it was contaminated with Pseudomonas, and it was clearly not to be used. It was to be used in a sterile environment, and people were receiving it as a drip. So it's not just about whether or not the antimicrobial itself is substandard or falsified. It's also whether the other products might be contaminated with a pathogen. So that's a problem. So we help with these analyses, and we facilitate connecting people together. And in some extreme cases, we might also connect and facilitate with replacing some products, but we don't buy that. It's just about facilitating with the genuine supplier.
Mm-hmm. And when WHO comes to town,
that helps sometimes.
Have you ever had resistance, where, they don't care that you're WHO?
It's about having the right carrot and the right stick. WHO is not a regulatory authority, but we help the regulatory authorities do their job well. So we are not the ones who give out the market authorizations, except for pre-qualified products, but that's a whole different deal. So this is about who has got the enforcement power. We bring technical assistance, and we support countries in building their capacity and their capability. But we're not a criminal investigation group, and we're not also a regulatory body. So we can only help the others.
Yeah, but it seems to work, which is really good. Let's hope in the world going forward, WHO will continue to have the same weight it does generally. So I'll turn to Ben now, put you to work a little bit, Ben. How much research has gone into the effects of substandard falsified antimicrobial production on the development of AMR specifically? Are we still at the level of speculation, or is there some hard evidence that this substandard falsification can actually drive AMR emergence?
I would say we're definitely still at the level of speculation. We don't have solid evidence that it's a major driving factor. It's certainly plausible, and the degree of plausibility varies per drug-bug combination. And it would be surprising if there was no impact of substandard and falsified medicines on resistance emergence. But it's also a complex and hugely under-researched area. We can do simple correlation analyses where we will see in geographic areas that have a high prevalence, or where we think there's a high prevalence of substandard and falsified antimicrobials. We also tend to see a high prevalence of drug resistance, but we shouldn't naively assume that's a direct causal relationship, because there's a large number of other factors that could be driving that, to do with failing health systems and so on. So we shouldn't overinterpret or get overexcited by such correlations. The types of evidence we have, there are some in vitro studies where antimicrobials with lower percentage APIs have been shown to be linked to the emergence of drug resistance. And the other type of study we have are modeling studies, where we can actually simulate the drug treatments that patients are getting, and we can build models within host dynamics, accounting for the pharmacokinetics, pharmacodynamics, and look to see what different dosing regimes have on emergence of drug resistance. But in general, it's a complex picture, and we also shouldn't always assume that substandard and falsified medicines are going to lead to more resistance. There are plausible situations where we might expect them to actually lead to less resistance. So, I mean, in one extreme case, if you have falsified medicines with 0% API, you're not going to be selecting for drug resistance. It's obviously not ideal from the point of view for treating infections, where you want drugs which work. But we also know a lot of antibiotic use is not needed for treating viral infections where they're of no use anyway. So I'm not saying it's a good thing. We don't want to be encouraging substandard and falsified medicines. But because it's a bad thing, we shouldn't automatically assume it's always a bad thing for drug resistance.
Yeah. So Ben, can you explain to our audience why, at least in theory, we would want either a high dose of antimicrobial or a low dose, very low dose maybe, but not an in-between dose to avoid this development of resistance? I will give you permission to totally geek out. I think our audience can handle it. Everyone should know Ben is a mathematical modeler, so hold on tight.
There'll be no equations in this. So, historical perspective. Paul Ehrlich famously said, I think in 1913, that we should hit infections hard and hit them early with antimicrobials. And I think he was thinking in the context of the best way to reduce mortality. But this has also been taken as advice for reducing resistance. There's a clear rationale for this. Having a high dose of treatment has two benefits. Firstly, you're suppressing the microbial population very quickly. So you're keeping that population down to low numbers. And the lower the numbers you have, the lower the chance you have of a resistance mutation occurring. So you can reduce the chance of drug resistance emerging from that population. So the second mechanism is that even when resistance does emerge, usually when it emerges, it doesn't emerge right away at a high level. It usually emerges at an intermediate level. And to get to a high level, you need a whole cascade of subsequent mutations. So when resistance first emerges, if the high dose is high enough, that's still likely to be able to suppress this partially resistant population. So the conventional view, and until a few years ago, this was the very mainstream view, is that higher dosing is always better as long as that's tolerated by the patient. More recently, that view has been challenged by some evolutionary biologists who've quite rightly argued that we also expect to see less resistance emerging at very low doses. And that's because at a lower dose, the relative advantage of being resistant compared to being drug sensitive is going to be smaller. And since resistance strains usually have an associated fitness cost, not absolutely always, but usually, we might expect to see them outcompeted by drug sensitive strains. So this is not necessarily considering the impact on how effective they are at preventing the patient from dying, but just from a point of view of resistance emergence, we'd expect to see this relationship.
Yeah, so that relationship relies really heavily, though, on this idea of fitness cost, right?
It does, yes. Yes, because if there was no fitness cost, even without treatment, you might expect resistance to emerge. And there are examples where there seems to be drug resistance, which spreads even in the absence of drug use. And there's nice actually examples with viral drug resistance where we've seen large-scale sort of emergence of drug-resistant, antiviral resistant influenza strains, which have not been associated with any antiviral use at all. It just happens by chance. So that can happen. But the usual picture is that in the absence of antibiotic use, most bacterial drug resistance has an associated fitness cost.
Yeah, I agree. And I think our audience is familiar with the concept of fitness cost. Right now, we're looking at our audience, actually, and a lot of our audience is infectious disease physicians and other healthcare workers related to infectious diseases. But we do actually have a general medicine audience. So maybe I will just quickly throw out there this idea. The idea is that the microorganism, in order to retain its resistance, its phenotype of resistance, there is a fitness cost to that. It's harder for the organism to, I guess, in a very simplistic way, kind of carry, express those genes that confer the resistance to it. And therefore, those colonies, they don't grow as well. They do very well in the presence of antibiotics or antivirals, something that's knocking out the competition. But when they're left to their own devices and there isn't this outside pressure, then the sister colonies will do better, the ones that are wild type, the ones that don't have to do this extra work of carrying or expressing these resistance genes. I'm making it very simplistic, but we do see that, in the clinic. If you leave patients alone for a while, for 6 months, 12 months, I see it in my practice where I treat a lot of patients with urinary tract infections. So they are big carriers of ESBL positive organisms. And if I can just get them off antibiotics for a while, they go back to wild type. It takes a while, but we do see it.
You see this also in these returning traveller studies where people just looking at the carriage of drug resistance, where people take stool samples from low resistance countries before they go on holiday to Southeast Asia, and they take stool samples afterwards, and then they all come back carrying ESBLs. And if they follow them over time, those ESBLs gradually disappear until after about 12 months or so, it's very hard to find them. And perhaps if I can just come back to then this relationship between this idea that these intermediate levels of dosing are likely to lead to the highest selection for resistance. I mean, it's worth saying that this has been sort of experimentally confirmed. There are, again, in vitro studies that show that this is indeed what you see. So it's not just a theoretical possibility, but it's something that we actually think is going on.
So, staying on a potentially geek track here, I have another question for you, Ben. Most of the audience, I think, will be familiar with the concept of the minimal inhibitory concentration, the MIC, which is the minimum concentration of antimicrobial necessary to prevent growth of a susceptible organism. You wrote about this recently. Can you tell us what the MPC and the MSW are?
Yes. So the MPC, the mutant prevention concentration, is the lowest concentration above which the single-step resistance mutants are prevented from growing. And the MSW, which is the mutant selection window, is the difference between the MIC and the MPC. So if you like, it's this window at which the dosing is able to select for these single-step resistant mutants. Mm-hmm. So that's the opportunity for these resistant pathogens to emerge. If the dosing levels are above or below that window, or outside that range, they will be inhibited, prevented from emerging.
Okay, good. So we're all on the same page, I think. What about bystander selection?
So bystander selection is incredibly important, but often entirely forgotten. Bystander selection is a term coined for the phenomenon where the bacterial flora of someone that's just sitting there, for example, the flora in the gut, which are not causing a clinical infection, but happen to be there because that's where the bacteria live. But they get exposed to antibiotics which are given for an entirely different reason, to treat some other possible infection that the patient has. So these are entirely innocent bystanding bacteria, not causing any problem, but the antibiotics are potentially selecting for drug-resistant variants of these. On the one hand, you might think this isn't a problem because they're only bystanders, they're not causing infections. But of course, in the future, they may go on to cause infections. They may be the source of future infections. And also, we know that the resistance genes don't stay in the same species, they actually jump around. So thinking, for example, for the gut flora, we know there's kind of rapid spread on plasmids of drug resistance between bacterial species. And it's actually been estimated that the vast majority of the drug selection pressure for resistance for most bug-drug combinations, for most important pathogenic bacteria and most drug resistance is due to this bystander selection. So we think it's really important in driving the spread of resistance. So it's something that we need to think about. I mean, both when we're thinking about emergence of resistance under normal antibiotic treatment, but also we need to think about the effects of this for substandard and falsified treatment as well.
Yeah, thank you. And this is something we definitely talk to our trainees about. The microbiota are just so various and so many, and what we think we're treating is not just the infection, right? We're treating all these other organisms and
that's right.
We're just waiting for disasters to happen.
Yeah. If you're only looking at the kind of target bug, you're only seeing a very small part of the whole picture.
Yeah. So for you, Ben, what is known about the effects of substandard or falsified antimicrobials on combination therapy? Do we have any data that, there's this interplay there?
Yeah, I wouldn't say we have clear data because, as we've heard, it's very hard to get good data. I mean, that's one of the things that makes studying substandard and falsified medicine so challenging, is the lack of clear data where we've got known exposures and known outcomes. So instead, we have to rely on sort of modeling and assumption-driven work. But that's certainly one area where it's been suggested that they are likely to be very important. And I think particularly in the context of emergence of resistance to antimalarials. So the idea of combination therapy, which, as we know, is widely used for malaria and TB and HIV, the kind of driving motivation of that is to prevent resistance emerging. And the idea is that even if you have a mutant emerging to one of the drugs used for treating the infection, if it's still susceptible, still sensitive to the other drugs, then that mutant won't emerge. And this has been an incredibly successful approach for preventing resistance emerging, because the chance of a bug developing simultaneously a resistance to multiple drugs is very small. It's just basic probabilities. When you multiply a small probability by a small probability, you get an incredibly small probability to the point where it actually never happens. The problem is with the potential use of substandard and falsified medicines, that may mean that one of the partner drugs used in that combination treatment is not effective. So effectively, you're undermining the whole approach of preventing resistance emerging. I think there are plausible reasons for thinking that may well be an issue in emergence of drug resistance. For example, some antimalarials with some falsified drugs, they may say that they are combination therapies, but actually they aren't combination therapies, but they just contain sub-therapeutic doses of a single antimalarial drug, in which case it's almost the perfect treatment you'd want to give if your aim was to select for resistance. So it would be very surprising if that wasn't playing some role in selecting for drug resistance.
We have talked now a lot about the emergence of resistance with substandard and falsified antimicrobials. What about their effects on transmission of infections? Pernette, has WHO seen direct evidence of increased transmission of infections due to these faulty antimicrobials? And I'm not counting the ones where the medicine is actually contaminated with a pathogen. Is there any evidence that there has actually been an outbreak because the treatment that was meant for the pathogen wasn't therapeutic in its concentration or was somehow faulty?
You're asking me the billion-dollar question, really. The link between substandard and falsified antibiotics and antibiotics is much more difficult to establish directly than, say, the resistance to malaria, because we're talking about so many different pathogens, so many different products and things like that. So a lot of it is hypothetical. And you add to that the fact that substandard and falsified medical products are a hidden trade. You know, once people have consumed the product, most of the time you don't even have enough samples left to analyze them. Like in the example I gave you earlier. There are seasonal outbreaks of meningitis C in the Sahel. And a few years ago, we had identified falsified versions of meningitis vaccines. And we had seen, now the correlation is very difficult to confirm and the causality even more so, but we had seen that there was an increase in the number of meningitis C cases at the same time as we had identified falsified versions of the vaccine circulating. So it's not that I'm taking out a joker card of public health. The bigger picture is probably that substandard and falsified medical products are actually a really good indicator of system failures. If you have got falsified vaccines circulating, there obviously will be a lack of treatment and a lack of protection. And you've got to be able to interrupt the chain of transmission, both of the pathogen, but also of the faulty products very early on. Otherwise, it's just not going to work. You were talking earlier with Ben about the hit hard, hit early. In a lot of countries, there are various constraints to purchasing the whole treatment course of antibiotics in one go. So one day they'll purchase from one supplier, another day from another supplier, and a third day from another supplier. So that means that one day you might get things which are of the appropriate quality, 100% API and 100% bioavailable. The next day it might be 50% API and 50% bioavailable, and then the next day it's 0%. So it's having this holistic picture. So it's more about if there are substandard and falsified products around, that's probably indicative of all sorts of other failures. It's about, the rational use. It's about, do people have access to the drugs they need at the right time? And then also looking at whether those products are of the right quality. So it's really, really difficult to make that direct link between direct transmission of infections and substandard and falsified antimicrobials. Because there are cases, as I said earlier, where you've got contaminations. But here we're talking about whether a product has failed to kill. And I'm not the expert on the subject. This is Ben. But the other day I was talking with a colleague and I was saying also, because when there are substandard and falsified medical product, it also means that people don't have access. They don't have physical access to the products. Sometimes some people will say, oh, it's much better if the products are falsified. There's nothing in them than substandard. But a lot of falsified products do contain a certain amount of active ingredient. And like I was saying, you've got to have a look at the whole treatment course. The mutation happens in a human host. right? So you do have a selection pressure, right? But the mutation could occur naturally in a human, regardless of selection. It's not the pharmaceutical that's going to create the mutation. So if a person stays infectious for a longer period of time, if the viral load, if the bacterial load is there because the person's not getting treatment, there's also a probability that there's at one point a mutation going to occur, and that mutation might be selected for resistance elsewhere. So it's a systemic thing that you have to look at.
Yeah. We haven't yet talked about solutions. WHO is monitoring this. So thank goodness you guys are having the big picture, keeping your finger on it on the ground all year round, I would say. So thank you to you, Pernette, and your team for being on the case around the clock. So Pernette, this question is for you again. If WHO or other organizations magically had $1 billion to spend, how would you tackle this problem?
So WHO has identified, these three kind of driving forces, which are constrained access, weak technical capacity, and poor governance. So you've got to attack it at those angles. WHO promotes what we call a prevent, detect, respond strategy. And there are lots of different functions in this strategy, but let me summarize it. Under the prevention thing, what you want people to demand quality. And this means that you've got to have procurers who demand quality from the manufacturers, from their suppliers, all levels of the supply chain, but also the end users who make sure that they're purchasing products from the right source. You don't go and purchase things from a dodgy website, social media. You don't go buy your cancer products there. Once quality is demanded, you've also got to secure the supply. And securing the supply means that you've got enough of the right stuff, that there are no shortages. That comes to the availability, but also that the right stuff that is already circulating in the supply chain doesn't degrade. So you don't insert falsified and you don't allow substandard to occur. And then under the detection pillar, you've got to make sure that things are detected. Detecting substandard and falsified medical products is super difficult. You've got to have the right tools who are given to the right people. But then once that's detected, it's got to be reported. We often talk about the commodities supply chain, but I'm always saying there's a data supply chain, the information supply chain. The people who can take action need to be informed on a timely basis. And once that is done under response, basically, the first thing is obviously you have to protect public health. So you've got to remove the threat, put the people safe and things like that. And then you have to prevent recurrence. So with substandard products, the response is going to be a predominantly regulatory response. And with falsified product, it's going to be a regulatory response, but it also has got to take into account a certain amount of criminal, judicial, legislative aspects as well. So our mantra is we've got to support countries and principally those who are responsible of safeguarding public health. So that's going to be the health authorities, national regulatory authorities, and they have to focus on market surveillance and control activities based on this prevent, detect, respond area. This prevent, detect, respond strategy is not only for health authorities, but it is predominantly for health authorities. So you have to engage with all sorts of stakeholders. And I would say when you're faced with a problem, the first thing is, what is this? So we have to reinforce the data collection activities. The work that we're doing is good, but it's not enough. And it's used to generate evidence. So we have to continue collecting this data and generate the evidence so that we can use that to develop appropriate tools in countries. Why are we getting reports, say, from, it's just an example, maybe only pharmacists or maybe only doctors? And why are we getting these reports for only certain types of therapeutic categories? What is it that's creating this bias? And is it because we're missing data? So even just the missing data, the gaps in itself speak volumes. But to have missing data, you've got to start collecting it. A message of hope is that in today's world, with all the technologies, you can actually leapfrog. You don't have to wait for the wire phone to be installed or the optical fiber internet to be installed. There are other technologies, and the same applies with prevention or detection or response technologies. And together we're stronger. I know this sounds so much, usual, blah, 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 but this really is the case. We need the information, and we've all got a different piece of the puzzle.
Wow. Of course. That's all logical. Like that's where you would have to put the $1 billion. What I'm understanding is you're basically saying it has to go to regulatory structures. It has to go to data gathering structures. And it's sort of heartbreaking, though, that the world right now, we're not there. We're just not there yet. And we have countries that are less and less invested in regulation.
Yeah, so if I may, just one thing as well, which is really important. It really is a global issue. In the same way that antimicrobial resistance is a global issue, the bugs don't know any borders. And today's world is a globalized world. People trade commodities all over the world. So this is really something where we're in this together, whether we like it or not.
Yes, I completely agree with you. So Ben, pressure's on you now. What would you say are the most pressing needs from the infectious disease standpoint? So we've talked a lot about knowledge gaps and missing data, essentially. But concretely, if you were given a ton of money to fill those gaps, where would you start?
I think ultimately a lot of the problems stem from failing health systems and all those kinds of issues. I would see the problem in the context of, as mentioned, the larger problem of access to effective drugs, in that if people had access, reliable access to safe, non-falsified antimicrobials, they would use those. Of course, the problem is a lot of antibiotic use is unregulated and informal. So I've worked for a long time in Southeast Asia. In many parts of Southeast Asia, you can go to the market and buy packets of pills that will contain one antimicrobial and a bunch of other drugs. And there's no marking, there's no labels. You have no idea what they are. People who are taking them don't know what they are. So there are clearly sort of major issues that go beyond the problems with substandard and falsified medicines in availability and use of antimicrobials globally. So I guess I would see it as part of that picture. If I had a ton of research money or even a little bit of research money to look at, is just how in the community settings in lower income countries, how people actually use antibiotics in terms of frequency, in terms of dosing, in terms of are they following the actual course? And if they are, is it always the same product, and the timing and so on? So we have actually very little reliable data on patterns of real antibiotic usage, whether substandard and falsified or not. And of course, I would like to know, and not just what percentage is substandard and falsified, but actually what the active pharmaceutical ingredients are. So what people are taking, where they're taking it, when they're taking it, and also why they're taking it. It seems a small thing to ask, but those data aren't really available. Although some work, things are getting better. So WHO work on the prevalence of substandard falsified medicines is incredibly useful. But generally, having that high resolution on how people use antibiotics in the community is lacking. So in hospital settings, it's a bit different. With that, we can get more reliable data. But for community usage, we don't have any great data. And it would be nice to get it. We tend to have sales data through official channels, but we don't know how representative that is. And it doesn't really help us that much to understand selection pressures at a detailed level.
So you would like to conduct a sort of global, multi-continental antibiotic period prevalence study, real life period.
But I would like to have people knocking on people's doors every day and asking them what drugs they've taken that day and actually looking at them. There are data a bit like that. There are these household survey data where people in some countries get asked if they've taken certain antibiotics. I think the problem there is that people don't know. If you ask someone, have you taken antibiotics? They don't know. Generally, people wouldn't know what's an antibiotic and what's not. So I think some of these estimates we get from that type of study is questionable reliability. So what's more useful if you can actually point to the packet and then ideally take a sample and see if they're substandard falsified as well, and actually see what they are and what people are actually taking. We have studies saying what people think they're taking, but that's not the same thing.
Yeah, it would be great to get a multi-level window into what the entire working population, what they're taking, how they're truly taking it, but also the medications, right? Like you were saying, where they come from, what state they're in before they even reach the patient. Yeah, maybe one day. So as we come to a close, Pernette and Ben, what are the key messages you would like to leave our listeners with? Pernette, I'll start with you.
I'll be cheeky again, and same as the advice, always ask and ask for help. And I think this is good with substandard and falsified medical products. I spoke earlier about how it's important to demand quality. So ask about the provenance of this medicine that you're buying. And if you've got any type of suspicion, check with your national regulatory authority. And maybe that will help. Ask what you're taking. Are you taking an antibiotic and things like that? Because it can also help the prescribing person. The most important is that the patients and buyers, they buy from safe sources. So that means a source that's been regulated and that's authorized for distribution.
Very, very important take-home message. Ben, what would your final message be?
So my key message is that this remains a massively under-researched area. We have good reasons for thinking that substandard and falsified medicines are having a major impact on human health now. And we really need investment in both sort of research to try and understand better how, but also to understand what we can do about the problem, both in the shorter term and in the longer term.
So thank you so much to my guests, Pernette Bourdillon Esteve at WHO in Geneva and Ben Cooper at Oxford University in the United Kingdom. And if you'd like to geek out a little more with Ben, you can do so by reading the excellent viewpoint he co-authored for Nature Communications last year. It's listed in the episode's show notes. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Angela Huttner in Geneva, editor at CMI Comms, ESCMID's open access journal. It was edited and produced by Dr. Kathryn Hostettler and peer-reviewed by Dr. Arjana Zerja from Mother Teresa University Hospital in Tirana, Albania. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks, and any literature we've discussed today can be found in the show notes. You can subscribe to Communicable wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.